Hello everyone, my name is Manaf Yusuf. I'm a junior doctor currently working in Bahrain. I'm going to be talking about the psychological impact of the COVID-19 pandemic, specifically comparing those that were placed in isolation to those that were placed in quarantine. As an introduction to the topic, the WHO declared COVID-19 as a public health emergency in January 2020. They advised for isolation of PCR-confirmed COVID-19 patients and quarantine of their contacts. Although we define isolation and quarantine as separate definitions, they both involve separation from loved ones, changes to the normal routine, limited physical activity, and dietary changes. All of these can have a significant psychological impact. Of note, psychological impact reported in pandemics is not something new. It has been previously reported in some outbreaks like MERS, H1N1, and SARS. Survivors of these conditions underwent social stigma, some of them suffering unemployment and other social contexts as well. The psychological impact during the COVID-19 pandemic has been studied in several countries, including China, where rates of depression have been reported as 17% and 35% for PTSD. Similar rates were found in Italy as well. In Bahrain, we had very strict measures of contact tracing and isolation of cases. All of the PCR confirmed cases were isolated and their contacts were quarantined. There were different locations, including at home and special isolation centers, and also some clinical settings like ICUs and for patients who required medical treatment. As for the international repatriation program, patients who came through the repatriation program underwent segregation from the general population. So the general objective of the study was to describe and to compare the psychological effects of the COVID-19 pandemic between those who were placed in isolation and those who were placed into quarantine. This is a cross-sectional retrospective study which included Bahraini adults, those that underwent isolation or quarantine, and we covered two different groups. The early group, which is from February to March 2020, and the late group that was in August of 2020. Telephone surveys were conducted by trained medical residents in August 2020. Now, to assess depressive symptoms, we used the CESD scale. To assess PTSD, we used the IESR scale. And to assess perceived stigma, we used the stigma scale. Now, as for the depression, scores of more than 16 were associated with patients who suffer from clinical depression, and for PTSD, scores of 24 or more were indicated clinical concern for PTSD. And in the stigma scale, we used the mean of the stigma variable as a cutoff point to assess whether patients perceived or did not perceive stigma. Now, all of the scales have been widely used and demonstrated reliability and validity in previous studies. As for the statistical analysis, the overall of the three scale scores have been reported as means plus minus the standard deviation, and for each scale band for all participants and for COVID-19 status. We used ANOVA and independent t-test to compare the means where appropriate, and we used Pearson's correlation coefficient to test the association between continuous variables. A p-value of less than 0.05 was considered to indicate statistical significance. As for the results, we had a total of 1,100 eligible subjects, of whom 502 participated. The rest were either did not answer, were invalid, or refused to participate. Of the 502, we had 301 who underwent isolation and 201 who underwent quarantine. Now the mean duration of segregation was 22 days for isolation, and the mean number of days was 12 for those that underwent quarantine. The general demographics for the participants was the mean age of 40 years. As for the sex, it was almost 50 and 50%. Most of them were married. Most underwent high school education or more. Had about a third of the participants were unemployed. Most of the participants were non-smokers. About half had comorbidities, and less than 3% had a history of mental health condition. This is a table showing the mean of the depression, PTSD, and stigma scores. And as we can see here, that the mean for all participants was 16.76%, which is more than the 16 value, which is considered to be associated with patients suffering from depression. About 40% of all participants scored more than 16, and it was more in those that underwent isolation. As for the PTSD score, almost 20% scored more than 24, which is associated with higher rates of PTSD. As for stigma, more than 50% scored more than 25, and it was more common in those that underwent quarantine with 64.2%. Variables that were considered to be statistically significantly associated with depression include sex, occupation, smoking status, history of mental conditions, place of segregation, transmitting the infection to another person, difficulty returning to work, social conflict, knowing someone who died of COVID-19, and their COVID-19 status. All of these were associated with increased CSD scores. As for the PTSD scale, it was associated with sex, occupation, education, history of mental health condition, social conflict, and knowing someone who died of COVID-19. The stigma scale was associated with place of segregation, transmitting the infection to another person, social conflict, and COVID-19 status. As for the continuous variables, we used ANOVA and t-test to look for any associations with the scores, and we found that the younger the age, the higher the scores in depression, PTSD, and stigma. As for the duration of segregation, it was found that the longer the duration, the higher the rates or the scores in depression. We used multivariate linear regression analysis to look for any predictors of psychological impact, and we found the following to be significant: age, sex, history of mental health illness, and COVID-19 status. All of these were found to be significant predictors of psychological impact. Based on the results, we have found that 40% of the participants showed clinically significant depression, with more in those that underwent isolation compared to those that underwent quarantine, and less than 20% had indications of distress, again more among those in isolation compared to quarantine. Some of the participants were diagnosed with PTSD, and stigma was perceived in more than 50%, although more in quarantine compared to isolation. Previous studies have showed that psychological impact is more profound in women and this precisely agrees with our results because it has showed that females exhibited more psychological depression and distress as well. Students were more affected compared to the general population. This is consistent with other studies, including one that was conducted in Bahrain just recently. People with pre-existing mental health conditions were found to be at the highest risk of psychological distress, and they should be targeted for psychological assessment and intervention as well. The strength of our study is that we use generic tools that are highly reliable and consistent. Now, we are also one of the few studies that studied 2 different periods during the segregation. Although we studied 2 different periods, these selected periods might not represent the whole pandemic. And also, we were unable to compare the psychological outcome immediately after the isolation and then months later to look for the prognosis. And also, we did not study the psychological impact of those who traveled for religious purposes because during the pandemic, the people who underwent repatriation, most of them returned from religious pilgrimage. Now, to conclude, we identified high-risk populations, we identified risk factors of higher psychological distress. These could be used to design effective psychological interventions. Also, the COVID-19 pandemic caused unprecedented psychological impact among the general population. To conclude, psychological interventions are urgently needed, especially in the high-risk groups. And finally, I would like to thank all of the contributing factors, all of the participants, and these are the references for the study. If you have any questions, please feel free to ask.